So, once again, good evening, everybody. I welcome you all to the second lecture under the is going to be on epidemiology and study design, as you guys already know. And before I forget, let me introduce myself. I'm Dr. Fatima Kinza. I'm the Vice President of Activities at GAMES, and I'll be your host for tonight. So, for tonight's lesson, we have with us the most esteemed Dr. Biswajit Chattopadhyay. Let me go ahead and introduce him to you. So, Dr. Biswadeep is a committed public health professional currently serving as a surveillance medical officer under the WHO. His field of work encompasses districts like Uttar Dinajpur, Dakshin Dinajpur, and Murshidabad, where, as a public health advisor, he provides technical support to the Department of Health, Government of West Bengal. He's actively involved in key public health domains such as vaccine preventable disease surveillance, immunization system strengthening, and outbreak investigation and response. His efforts are focused on improving health outcomes through robust disease surveillance and evidence-based interventions. Dr. Biswadeep completed his MBBS from Medical College, Kolkata, and earned his MD in community medicine from the esteemed All India Institute of Hygiene and Public Health. He brings extensive expertise in epidemiology, nutrition and public health, occupational health, biostatistics, clinical research methodology, and health education. Since 2019, he has also been associated with the MindRVA coding platform at AIIMS New Delhi as a registered virtual autopsy coder. His academic contributions include multiple publications in peer-reviewed index journals, along with recognition through several awards at both state and national level public health forums. Dr. Biswadeep has a keen interest in mixed method research and the application of GIS, that is, the Geographic Information Systems, to tackle complex public health issues, reflecting his commitment to innovation and interdisciplinary collaboration in public health. A most hearty welcome to you, sir. So we look forward to learning from you tonight. Over to you now. You can go ahead and start sharing your PowerPoint presentation for us.
Thank you, Fatima, for your brilliant introduction. I don't know if I'm deserving of such kind words. So can you hear me?
Yes, sir, we can hear you.
Okay, thank you. So let's start with the second series of this research methodology workshop. So today's topic, let me share my screen. Can you see my screen?
Yes, sir, we can see your screen.
Okay, thank you. Okay. So today's topic, as you know, is one of the most important and fundamental topics when you want to do any type of research or you want to venture into any type of epidemiological studies or public health projects or any type of policy making decisions. So today's lecture or today's study, I will try to divide it into three categories. So first of all, we will discuss on the disease frequency. Then we'll go to the different types of studies present. And lastly, we will discuss about the concept of validity. So first of all, I want this the study period, I want this workshop to be interactive. So whenever you have any type of doubts, please note it down. After each of the section, I will stop for a discussion, FAQ or question answer period. Then I will proceed to the next part. So Fatima, is it okay that I continue? Hello.
Yes, sir, noted. Please.
Okay.
Yes, sir.
Okay. So starting with epidemiology. So what is epidemiology? As we know, our textbook definition of epidemiology, which is given by John M. Last, it is the study of distribution and determinants of health-related states or events in specified populations and the application of it to the control of health problems. So what is it? In simple language, epidemiology is the study of reasons why the disease is happening, to whom the disease is happening, what type of disease is happening, and the distribution of the diseases. So mainly there are three parts. First of all, the frequency of the disease. Secondly, the distribution or the pattern of the disease. Mainly the descriptive epidemiology part or descriptive researches deal with this distribution. And finally, the determinants of the disease. Here, analytical studies uh, take the upper hand, and we have some hypotheses about the etiology of the diseases. So, if I just summarize, there are 6 questions for every disease or every health-related events. We have to ask these questions, and epidemiology give us the answer of all the questions. That is what, when, where, whom, or in whom, why, and how. So let us go ahead with the measurement of any diseases. So whenever we call about any disease, let's say we say that there is X amount of measles cases, or there are Y amount of acute gastrointestinal disorders in a particular hospitals. So here, either we say some absolute numbers, or we do some comparative analysis or comparative values. So what do you mean by absolute numbers? Absolute numbers means just the number of the diseases. And when we do some references or comparisons, when we have some numerators and denominators. So first of all, we have to understand whenever a case or disease is there, we have to have a specific case definition. It can be statistical, it can be clinical, like if you have a spectrum of blood pressure, you know that your systolic blood pressure, if it is more than 120, or diastolic blood pressure, if it is more than 80, then you are going into the diagnosis of pre-hypertension. So this is a part of clinical diagnosis. There might be some prognostic diagnosis. Maybe there is some biomarkers which is prognostic of some chronic diseases. So there are some specific set of case definitions. And the cases, they might be dichotomous. Like either you have the case, or either you have the disease, or you don't have the disease. And it might be of some continuous spectrum, which is like if you have some blood sugar level or cholesterol level. We all know that if our random blood sugar level it is more than 140 milligram per dl, then we will have said to have impaired glucose tolerance or pre-diabetes. So this is a spectrum which naturally have some cutoff values. So there might be 2 types of case definitions, dichotomous case definitions and spectrum. This will be very important to understand when we go to the validity part. And when we are coming to the comparison part, there are mainly 3 types of fractions or 3 types of references. One is rate, another one is ratio, and lastly proportions. And we mainly compare between exposed and non-exposed, maybe some risk factors or maybe some preventive factors. And we can also compare the data or compare the analysis between diseased person versus non-diseased person. So to have the understanding of disease and non-diseased or exposed or non-exposed, firstly, we need to have a very good idea about the case definition. So coming to the proportion part, coming to the different types of references or fractions in a disease frequency. So proportion is where there is one numerator and another denominator, and they are related. And the numerator, it is actually a part or subset of denominator. So when the total number of, let's say we are trying to find out that the total number of, out of total number of, let's say factory worker, how many proportion of factory workers they have occupational lung diseases. So this is called the proportion of factory workers who have occupational lung diseases. So this data set, or the data of the disease, or this frequency of the disease is called proportion, and mainly it is expressed as percentage. And the other one is ratio. So what is ratio? Ratio might be interpreted as a fraction where numerator and the denominator is not related, and also the numerator is not a part of denominator. So there is a concept called, you all know that sex ratio. Sex ratio is the ratio of female, which is in the numerator part, divided by the ratio of male. So thereby we can get a ratio. If I go to a little bit disease related or epidemiological related ratios, there is a concept called maternal mortality ratio. Here, the numerator is number of maternal cause related deaths divided by number of live births in a particular period and place and uh, in a particular period and place. So here, the numerator is the number of mothers and the denominator is the number of live births. So they are not related. That's why it is called ratio. Rate, it is actually a fraction which can be proportion or ratio, but where the denominator or a part of the denominator is the time. So any type of duration, if it is having their place in the denominator, the total fraction converts into rate. So we need to be very cautious about telling which is proportion, which is ratio, and which is rate. Now, we are going to the basic few definitions by which we actually define or we actually calculate the disease frequency or disease percentage. So one of these very important measure is called incidence. So incidence is actually basically a rate, as we discussed. It is a fraction where denominator is the time period or average duration. So what is incidence? I will not tell you the bookish definition because we all have the access to all our textbook. I want this particular seminar to be interactive and to so that you can learn from the practical sense, from the field that I am having a part of myself. Anyway, incidence actually it is nothing but a value of new cases in a specific time, place, person, setup. So what is it? Maybe there is, let's say in a particular hospital, maybe in AIMS Delhi, in 2025, there is an incident of a new case of, let's say, ILI, influenza-like illness. And from 2025, there might be 3,000 cases of ILI in AIMS Delhi. So we know the time, it is 2025. We know the place. It is patient admitted in AIMS Delhi and person. So what is the person? Person will be the susceptible or risk group. So in this case, the risk group might be any of the person. ILI is can happen to anybody. So in this case, the numerator will be number of ILI cases, new cases, and the denominator will be the susceptible risk groups may be among this particular population in this particular time and in this particular place. So this is called incidence. So incidence is very important in which type of diseases? As I gave one of the example, it is important in acute diseases or short-term health events, where the disease is not for so long. There might be some outcome very fast, might be recovery, might be death, might be disability, but it is for a short duration. So for that, incidence is very important tool to so that we can have the disease frequency calculation. And incidence can also be used to compare between time periods. Uh, there are maybe different time periods where we can compare the incidence. So, and there might be different areas, like we can compare the incidence of measles in different states of India. So we can have comparison of, let's say, diphtheria in different person groups, maybe in male, female, maybe in employed person, unemployed person, maybe in different age groups. So these type of comparisons is can be done with the disease frequency value, which is called incidence. And it is also used to compare multiple interventions. We will come in the experimental study design about this thing. Uh, the slide is not moving. Okay. Uh, So now coming to the next or the second disease frequency value, which is called prevalence. So what is prevalence? Prevalence is all the new cases and also the existing cases that are there in a specific time, space, or person setup. So it is actually total number of cases at a particular point. It is called prevalence. So prevalence is actually important or beneficial in case of rare or long-lasting diseases, where incidence might not be very beneficial. There might not be any diseases at all in a specific time, or there might not be any new diseases in case of long-lasting or chronic disease. So to have a comparison or analysis of chronic diseases, prevalence is more important. There are two types of prevalence. One is point prevalence. Another one is period prevalence. So point prevalence is like a snapshot. Maybe for today, if I want to see for today, there is how many notifiable diseases included in the IDSP formats, P form. IDSP is one of the disease surveillance program in India. So if I want to know about, if I want to see about this thing, I will go to the portal of NCDC and I will see that there might be X number of notifiable diseases uh, notified today. So this is a point prevalence. But if I want to know about the total number of diseases reported in a particular time or in a particular place, or maybe total number of cases not only reported, present in a particular time, let's say 2 or 3 months, it is called period prevalence. So there is a fine difference between incidence and period prevalence. You need to understand this. In case of period prevalence, we actually multiply the incidence with the average duration. So let's say if we want to know about incidence of 1 year, incidence of 1 year, maybe it is 10. But we want to know the period prevalence of, let's say, 5 years. So we will multiply the incidence with the average duration, that is 10 into 5 equals to 50. So at the end of the 5 years, we will have 50 total cases, which is the period prevalence. Okay. So the concept will be more clear in this next slide, where we have a visual representation of period prevalence. So here each horizontal line represents a person. So here the dotted line represents a non-disease state. The straight line actually represents where any disease or health events is going on. And O means disease onset, R means recovery, D means death, and M means migrations. So the persons or subjects under investigations, they are going outside of the study purpose or study area. So in this case, if we consider the T1 snapshot time, let's say T1 is January 1st, 2025. So here we are seeing only two straight lines are intersecting the T1 line. So in the T1 time, the point prevalence will be 2 divided by 10, because there are total of 10 participants or 10 study subjects. If we consider T2, in T2 line, I think three horizontal straight lines, they are intersecting the T2. So in this case, the prevalence will be 3, but not divided by 10. It will be 8, because the 5th and the 7th line, they actually migrated out. So the denominator always, in case of all disease frequency, the denominator is at-risk population. So they will not be a at-risk population because they are not there in the study time. So the point prevalence in T2 will be 3 by 8. But if we consider about the period prevalence, so the period prevalence between the time of T1 to T2 will be all the cases that have been there during this time. So we can see that the second line, the third line, the 5th line, 6th, 8th, and 9th. So there are 6 lines, straight lines, or 6 diseases that are present during this particular time. So the period prevalence will be 6 by 10 into 100%, that is 60%, or we can say by like that 60 per 100 population. But if we consider incidence in this particular time, let's say from T1 to T2, this would have been only the new or incident cases. So it wouldn't have be the amount of 6. It will be only those cases which have their onset after T1. So it is the third line, if I say correctly, sixth line, eighth line, and ninth line. So the point prevalence is 6, but the incidence is 4. So this is the fine difference between point prevalence and incidence. What I just discussed, we can see in the lower part of the slide that the point prevalence of at time T1 is 20%, point prevalence at time T2 is 38%, and the period prevalence between T1 to T2 is 60%. So you need to be very cautious and you need to be very vigilant when you are calculating different types of incidence rate and prevalences and doing your data analysis. You have to be very cautious about the time. Okay. So apart from incidence and prevalence, there is another uh, disease frequency value, which is called mortality. So mortality is nothing but incidence of death from disease, if we can see in a simple yet simple or colloquial term. So mortality actually is a satisfactory proxy for incidence if survival is not related to the risk factors under investigation, which means that if there the diseases, if happens, maybe some very serious diseases where there is no cure, in that case, the number of mortality, it is actually near or similar to the incidence in a particular time. So mortality is also one of the types of disease frequency. So all these 3 types of disease frequency that we discussed, it can be differentiated into 2 types, which is crude value and specific value. So all these differentiating types, the crude and specific, depends on the denominator, not the numerator. Like we discussed the numerator till now, but if we consider the risk population taken as a whole, maybe the total population of a particular state, or maybe the total population, total patients admitted in a hospital. If we say like this, or if we analyze like this, the rates will be crude rates, crude mortality rate, and different rates. But when we substratify or subdivide the risk population or the denominator, then we go to some specific rates. It can be age-specific mortality rate. It can be sex-specific mortality rate. Different types of substratification or specification can be utilized to have specific mortality rates. Now, going to have some special rates. Like these are also measures of disease frequency, but not incidence, prevalence, or mortality. So what are they? They are like birth rate, fertility rate, infant mortality rate, stillbirth rate, perinatal mortality rate, different types of rate. So what is the difference between this and all the 3 measures of disease frequency that I discussed earlier? Here, the denominator is actually a quasi at-risk population. That means the at-risk population is not well defined. So we ourselves devised a artificial at-risk population. Such as in case of birth rate, the denominator is mid-year population. So we will have a mid-year population that will be the denominator. It need to be formulated. It need to be calculated. Same is for fertility rate. Fertility rate is number of average children born by women of reproductive age divided by the number of reproductive age women, 18 to 45 years old, in a mid-year population or in a mid-year term. So everything here, it is the at-risk population, it is actually calculated and usually relates to 1 year. Similar to the infant mortality rate, it is the live birth, total live birth in a year. Stillbirth, the denominator is also the number of live births, and perinatal mortality rate also the number of live births. Now, when we compare these disease rates, what I just discussed, some of them are like incidence, prevalence, mortality, and some of them the special rates. If we compare these disease rates, we compare actually the frequency among some exposed or unexposed group mainly. So there are three types of risk that we deal with when we compare the disease rates. So first, the definition is called relative risk. So what is relative risk? Relative risk is the ratio of the disease rate in exposed person to that in people who are unexposed. So the incidence among, let's say, exposed person divided by the incidence among non-exposed person. So if we consider two groups, maybe smokers and non-smokers, and we try to uh, calculate the incidence of COPD in these two groups. So the incidence of COPD in the smokers divided by the incidence of COPD in the non-smokers. This ratio is called the relative risk. So this actually gives us the estimation of how many times a factor or exposure will increase the incidence of a particular individual. Or in a simple term, it will measure the strength of association between exposure and the disease. So this is actually important for all the clinicians and the researchers. The next one is attributable risk factors. So we know that a particular exposure is responsible for the disease, but we don't know out of the total disease incidence, how many or how much of the proportion is attributable to the particular risk factor. So this is nothing but the difference of disease rate. Earlier, it was the ratio. Attributable risk factors or attribute risk is just the difference of disease rate in exposed and that of unexposed. So it is actually the incidence among exposed minus incidence among non-exposed, and the denominator will be incidence among exposed. So it actually denotes how many times a factor or exposure will increase the incidence rate of a group. So this is actually important for the epidemiologist and public health specialist, because the public health programs and all the epidemiological studies, they are dependent on this attribution. And lastly, population attributable risk. So this is difference of disease rate in the whole population and that of in the unexposed population. So it actually denotes that how much the risk of disease in a population will decrease if the factor is reduced to the level of unexposed. Which means if all of the people in the particular society, they stop smoking, then how much of the incidence of COPD will reduce? It is called population attributable risk. So this population attributable risk, this type of comparison, it is important to see the protective value of any public health intervention. So if let's say we are doing some particular public health interventions, like if in any case there might be a surge of malaria or dengue cases, and there may be some public health intervention in place, like distribution of insecticide treated bed nets. So after, let's say, for a while, 1 or 2 months, we see that all of the persons in the particular area, they have gotten that insecticide treated bed nets. So all of them have become the unexposed part or unexposed group. After a while, that incidence of dengue, let's say, decreased by 40%. So in that particular example, the population attributable risk for this particular exposure, that is insecticide treated bed nets and the disease dengue, is 40%. This is actually important for policymakers and administrators, as you all might have understood from my example. So then we are going to another one in case of one of the very important and interesting topic when we compare between diseases or compare between disease frequencies. It is called confounding or confounders. So confounders is a third factor outside the conventional effect and disease diaspora. So confounding factor or confounders are just a factor which determines the risk of disease or risk of development of disease independently from the exposure under investigation. So it is independent. It is not dependent on the exposure. It is not dependent on the outcome. But from outside, it can affect or it can affect the it can affect the causation of the disease, or it can increase or decrease the incidence rate from outside. So how to reduce confounding? So we need to know that also. When we try to compare between different type of disease frequencies, be it incidence or prevalence, we need to know about how to be protective from the confounding factors. So there are some methods. I will not go into the details, but there are some methods by which we can reduce the confounding. So first is called stratification or matching, that we will discuss in the study designs also. Another one is standardization. There is one thing called adjustment by mathematical models, which is also represented by regression equations. And lastly, randomization. So what is stratification? Stratification is we will try to match the exposed group and a non-exposed group in all similar way except for the exposure in investigation. So they will be like a similar age group. They will be like similar uh, gender distribution. They will have similar socioeconomical distribution. So all the factors that we know, we can reduce by matching. So from matching, we can have reduction in uh, known confounding factors. There are some other ways like standardization. So standardization is what? When we try to compare the incidence rate of two groups, we try to compare it with a reference population or reference sample. And we try to have ratio analysis of your particular study sample to that reference sample. Another one, as we say, that adjustment by mathematical models. Here, actually, the models, they assume that the disease occurrence, it may be incidence or prevalence, it is nothing but a mathematical function of different variables or different exposures. So they just adjust all the exposures in a computer, and then they give the actual values. And lastly, randomization. Randomization is randomly treating or randomly allocating your uh, exposed and non-exposed group people to have a better chance of reducing confounding. Randomization is only applicable for experimental study design, not in any other type of studies. So if we go to stratification or matching that I told, it can only be used to reduce known confounders. So here in this particular table, if you can see, the deaths in male in Bournemouth and Southampton, two coastal town in UK, it is shown here. So if we go to all age death rates, then we can see that annual death rate per lakh in Bournemouth, it is 1694, 1694. And in case of Southampton, it is 1190. So by these two information, you can deduct that there might be more morbidity and mortality among the persons residing in bone marrow. Or there might be some other factors which is causing bone marrow to have more annual death rates. But if we stratify the population, then we can see this increase in annual death rate, it it happened because there is more number of geriatric persons in the city of Bordeaux. So when we stratify with age, the annual death rate becomes comparable. So this particular confounder in this case was age. So this is one type of stratification. Standardization. Standardization, it is, sorry, the spelling is incorrect here. Anyway, standardization can be direct and indirect. So you need to be very cautious about using where you use direct standardization or indirect standardization. Direct standardization can only be used if it is a large study and you have a very accurate and specific data on a reference population. So here what we do, we do a comparison of weighted average of factors, which is mainly age and sex, specific death rates. And the weights actually are equal to the proportion of people in each group. In each factor group means in each maybe age group or maybe each gender group from a convenient reference population. So it is very tough to just read it out. So if we go to the example here, we can see that they have given an example of direct standardization based on mortality from coronary heart disease in men in the US. So when we are having the death rates, the one column, it is the death rates in a particular age in your study sample. And the reference population, here the second type is the proportion of reference population in age groups. So in America, they are seeing that percentage of reference population in there is 35, the 35 to 44 years population, they are 34.4% of the total age in American population. So they are weighting this 34.4% into their death rates. And it becomes like 3199.2. By this, they are having their total death rate. It becomes like 443 per 1 lakh population. So this 443, the ultimate death rate or the standardized death rate, it is standardized by age group and comparing with a particular set of reference population, the US population. So we have a reference population, we compare the reference population with our own population value and we get the standardized death rates. This death rate is devoid of any bias which might have come from our study selection. And there is another type of standardization. It is called indirect standardization. It is actually suitable for small surveys or where you don't have any accurate data on the reference population. So here, the comparison of observed value is done with the expected value in a similar reference population. So you don't have a standard population, but you have a similar reference population. So let's say a clinician or a chest specialist, he is trying to find out the number of paroxysmal coughs in a particular age group in a particular period of time. So here he first divided his study population into different type of age groups like 35 to 44, 45 to 54, etc., etc. And then he had the symptom prevalence in the preference group. So he has a, let's say, a review of literature or previous studies have been done in a particular age group. He has the data on how much is the symptom prevalence. So he will have the expected case in his own population. So in this example, we are seeing that among the age of 35 to 44, the symptom prevalence in the preference group is 8%. And the total number of participants or patients of that particular clinician is 150. So the expected case of paroxysmal cough should be 12. So by this, from each factor group or age group, they can have the total number of expected case. It is called maybe 30 in this example. And in this particular example, the clinician actually found 45 cases from his sample of 340 patients. He found 45 patients who had paroxysm of cough. So the expected value was 30 and he got 45. So we can say that he got 150% more than the expected or standard value. So this is actually called, this ratio 150% or 45 by 30. This ratio is actually called standardized morbidity or mortality ratio. As we are in this particular example talking about a morbidity, which is let's say paroxysmal cough, then it is standardized morbidity ratio. But if we are comparing death rates or mortality rates, as seen in the previous example, then this particular ratio is called standardized mortality ratio. So in very simple terms, how to do and when to do different type of standardization. You will do direct standardization when your target population will have the specific rates, which might be mortality rates, and you will impart your specific rates into a standard population group size or population size. So your rates multiplied by the proportion of the standard population. If this is the method, then you are doing a direct standardization. And in indirect, it is just opposite. When your target population will say the group size and your standard population, or in this case, it should not be a standard population, it should be a similar population or similar reference population, it will have the group specific rates. So if we go in the previous slide once again, in case of indirect, the target population will have group population size. So the first column, it is the target population and we have the group size. The second column, it is the standard population and we have the specific rates. So target column, target population, we have the group size. Standard population, we have the specific rates. So this is indirect standardization. And in case of direct standardization, it is just the opposite. Here we are seeing that the prevalence is from the standard population and the death rates, it is from the target population. Okay. So now we are going to have, we will progress or we will proceed to the descriptive studies. I will ask Fatima to have discuss if there is any queries in the chat box, then we can shortly answer those and we can proceed to the next section of our seminar. So I'm stopping my presentation, or I'm stopping sharing my presentation. Is there any questions in the chat box?
As of now, no, sir. It doesn't.
Okay, no problem. Then we will handle it at the end of the seminar. Thank you.
Done, sir.
Okay. So now descriptive studies. So we know about the different disease frequency. We know how to deal with diseases and what to do if we get some type of data or some type of information thrust upon us in case of any disease or health events. Now we want to do some studies, right? We want to know about the whys and whats and whens of the health events. We want to know who are affected. We want to know their age, gender, ethnicity, occupation. We want to know the details of the persons. We also want to know the geographical patterns from where the disease is happening and in which time it is happening. It might be some seasonal trends. It might be some abnormal occurrence or more than normal, exceeding the normal occurrence, which we call outbreaks. So we will try to know about the person values, place values, and time values, which is the questions that I discussed at the first slide: who, where, and where. So descriptive studies actually focus area is just to have the details of person, place, and time distribution of any disease or health events. The main purpose is to identify patterns, if there is any, and generate hypotheses for further researches. So descriptive study itself, it doesn't conquer so much value in the evidence triangle, but it is the starting point of our hypothesis. So descriptive study is to have the idea of a details, time, place, person distribution of a disease and to generate hypothesis for further researches. So there is some feature of descriptive studies. You can have your own original data, but mostly descriptive studies, they use existing data like registry, clinic registries, death registries in case of mortality studies, hospital records if you want to have disease data from a particular hospitals or population surveys. So all these type of things is called secondary data analysis. You are analyzing the data which is already present and you are generating a hypothesis from it. So it is called secondary data analysis. But the most important findings or most important feature of a descriptive study is that it actually have a non-causal approach. So the observers or the study participants, they will have some patterns and the observer will describe the pattern without establishing any cause-effect relations. So descriptive studies are only for description, for no association or causation. You need to have this important this is the difference between, we will come later, difference between longitudinal and descriptive and experimental studies. Okay. So in case of analytical studies, you are trying to have some cause-effect relationship. You are trying to establish some cause-effect relationship. You are trying to mold your hypothesis in that particular arena. But in case of descriptive study, the approach is non-causal. So there are mainly three types of descriptive studies. Case reports that I think all of you have seen in all the journals. Case report is just a single patient or a small group of similar patients, and you will have to have a detailed description. And that description must include the time, place, person distribution. That is common for all the studies. This is called case report. Another one is case series. This is a collection of case reports grouped together. Maybe a pattern of cases, a pattern of new cases among a type of patients or among some patients where the pattern is not seen before. So you are interlinking the case reports in a case series. And lastly, a cross-sectional study. Cross-sectional study is also called a snapshot study. So you are taking all your observations, you are compiling your observations at a particular period of time. So cross-sectional study might be descriptive and it might be analytical. When you are only doing the description and nothing else, the cross-sectional study is a descriptive study. For example, if you want to know the prevalence of smoking in a population, you take a target population, you select a study population, then you have some sample size estimation, sampling procedure, and then you come to a study subjects or your study sample. In that particular study sample, you study about these 6 questions: what, whom, where, when, how, and why. And I will just regress my word one thing. Why is not that much important in case of descriptive studies. Here you are only seeing the prevalence. But when you are trying to see any type of risk factors or associated factors among the smokers or among the exposed groups, then it will be an analytical study. It might be cross-sectional or it might be longitudinal. But if we consider the risk factors or if we consider the determinants, in the definition of epidemiology, there is distribution and determinants. If we stop at distribution, it is descriptive studies. If we venture into the determinants, we will go to the analytical studies. So there are some strengths and limitations for all the studies. I won't be saying or I won't be delineating about the strengths and limitations of all the studies. I want the students or I want the attendants to have their own notes about what could be the strengths and limitations for each of the studies. So I will just say about descriptive studies. It is, as you know, it is very easy to conduct and inexpensive. Actually, it is useful for public health planning, because if you see, when we, the core public health specialist, we do some planning for some programs or maybe new initiatives or interventions or maybe change in existing programs. The descriptive study is very important. The trends is very important. So public health planning is actually dependent a lot on descriptive study. Most of the public health planning is dependent on descriptive studies. It is important for hypothesis generation also, and it provides baseline data for further research. The limitations similar, cannot determine cause-effect relationships. It is susceptible to bias, obviously, selection bias. It is present in all types of studies. And also it is limited by the quality and completeness of available data. Because during descriptive studies, most of the time we have to depend on the secondary data. And as it is the first step of hypothesis generation, the quality of data is not so good always. So when we go ahead of the descriptive study part, then we will have some classification of studies. So you need to be very careful about how to classify analytical studies. So analytical studies mainly of two types. One is when your unit of study is a large country or large community. It is called ecological studies. We won't be having a discussion on ecological studies today. We will focus on the studies where the unit of analysis is individual. So here we can see there is a cross-sectional study and a longitudinal study. So cross-sectional study can be descriptive and also analytical. Cross-sectional is there is no temporal movement of your study protocol. Longitudinal study is either you will go forwards or you will go backwards. Or if I can classify it in another form, either you can just observe the natural progress of the disease or natural history of the disease, or you either you observe or manipulate from your part. So if you manipulate, then it is an experimental design or experimental study. So observational study are mainly of two types, cohort and case control. Experimental study, there are many types of experimental studies. I just written only three, but you can have a lot more. There might be 10 to 15 types of experimental studies. One is randomized control trial, non-randomized control trial, and community trial. So the main difference between RCTs and community trial, it is that in case of RCT, the unit of analysis is individual. We will just analyze the disease patterns or health event patterns or compare the patterns among individual people. And the community trial, it is the unit is a large community. It might be a district, it might be a state, it might be a country. So this is the main difference. Now we will venture into the analytical observational studies. So there are mainly two analytical observational studies. One is cohort and another one is case control. So you have to have a clear idea about what is cohort. Cohort is nothing but a group of people who share a common characteristic or experience within a defined time period. So your time period is your study time period. And here the cohort is similar population or population with similar and relevant characteristics relevant to your study. So we will only select a cohort of people. We cannot select random people. So cohort, there is some examples. Birth cohort, it is the group of people born in the same time period, maybe a year. Let's say the persons were born in 2000. We will take them only in that particular study. There is one thing called exposure cohort. Persons exposed to common drug or vaccine or infection within a defined time period. It might happen that all of them are exposed to, let's say, paracetamol or have taken paracetamol in a particular year, or they have been infected with any type of bacterial diseases, or they have been administered, let's say, adult vaccines. Adult vaccination, as you all know, BCG vaccination is going on. So this is also a type of longitudinal study that we will come later. So these are the type of cohorts. Now, you need to know some of the features of cohort study. These cohorts that we discussed, they need to be identified prior to the appearance of disease under investigation. So let's say we are trying to investigate a disease, maybe lung cancer, and we are trying to select a particular cohort. So what cohort we can use? We can use birth cohort, we can use marriage cohort, but it will be better if we use some exposure cohorts which is related to, or which you are making a hypothesis on, which is related to the disease, that is lung cancer. So cohort study feature is the disease must not happen, and the cohort should be identified before the appearance of disease in that particular cohort. The study groups, they will be observed over a period of time to determine the frequency of disease. That is the incidence that we discussed, and we will compare the frequency of the disease. So essentially the study will actually proceed forward from cause to effect. So there are cause or there are exposure or risk factors when you are trying to start the study, and you will continue or you will follow up until a specific proportion of the cohort will get the disease. So there might be some consideration before or during selection of cohort. As I said, cohort must be free from disease under study at the start of the study. And second point is very important, both the groups. So there is two groups. You will essentially compare between two groups, exposed group and non-exposed group. But both of the groups should be equally susceptible to the disease. So that is interesting. You know that one group is having a particular exposure. You know that another group is not having the exposure. But both of the group are susceptible to the disease. Let's say if I consider measles, all of us are actually susceptible to measles, irrespective of some of our exposures or protective factors. So you need to be sure that your exposure group and your control group, it is not control, it is your comparison group, they will be equally susceptible to the disease. And both the groups should be comparable in respect to all possible variables which influence the occurrence of disease. So the third point is what we discussed earlier, to reduce the confounders. So we need to be very cautious about all the possible variables, which is all the possible confounders which might influence the occurrence of disease. So this third point is actually essentially called matching. And lastly, diagnostic and eligibility criteria of the disease must be defined beforehand. So you need to know very accurate case definition of the disease. The disease cannot be a new disease, or disease cannot be a disease with no particular diagnostic criteria. So if we need to actually able to diagnose the disease before starting any cohort study. So there are some steps of cohort study that it is written in all of your textbooks, but I will just go through some of the important points in each of the steps. So the first step is selection of study subject. You can select your study subject from general population. You can have a special group, maybe all doctors as we are here, maybe all lawyers. And you can also have some exposure groups, which means that uh, maybe mine factory workers. They have exposure to, let's say, coal dust, and you are trying to have a study, or you are trying to investigate or develop a cohort study to understand the association of occupational hazard and maybe pneumoconiosis. So there are some particular group or particular cohort, they have a particular exposure. You can select them also. Then obtaining data on exposure. So there might be two types of exposures. You have to be very cautious about this. One type of exposure is dichotomous exposure that we will discuss in our uh, analysis part. Dichotomous means either there is exposure or there is no exposure. But it can also be done by the severity of exposure, which means you don't need to have the dichotomous value of exposure. All of the persons or all of the groups or people might have the exposure, but some of them might have severe exposure, another group might have mild exposure. Then you are going to select, going to have do the selection of comparison groups. The selection of comparison groups can be internal comparison or external comparison. External comparison is from other population and internal comparison is from the similar or same population. Then you will do periodic follow-up. And lastly, you will have analysis. What will you analyze? All the three comparative disease frequency values that we discussed. RR means relative risk, AR means attributable risk, and PAR means population attributable risk. So there are some different type of cohort study. What we said, it is prospective cohort study, right? It will go just forward from the cause, the effect to the cause. Sorry, the cause to the effect. So if we start a cohort study right now and you go for, or you follow for, let's say, 2 or 3 years, then you will have a study type which is called prospective cohort study or concurrent cohort study. But you can also have a historical cohort study, which is called retrospective cohort study. Here you have the data of exposure and disease. Already disease have done, have occurred. But you are not going backwards. You are going back to the time or period where there were only exposure but no disease. Then you just follow through all the records or other sources of information to come up to the present time where diseases have occurred. It is called retrospective cohort study. And what is prospective on retrospective? It is nothing but following on your retrospective cohort study to a future period of time, which means you are doing a historical cohort study, you are doing a retrospective cohort study, but you are not stopping at present time. You are continuing your cohort to a specific future period. So you are doing a prospective on retrospective study. So there are three types of mainly cohort study. There is another interesting thing. It is called double cohort study. So what do you mean by double cohort study? Double cohort study means when there is not one cohort, but two different cohort. So what is the difference of double cohort from the conventional cohort studies? It is used when there is maybe some mishaps or maybe some events that is of of high magnitude, and it is of maybe national public health importance, and you don't have a a big enough cohort for comparison. It might be, one of the examples might be that there is some chemical leak in a particular factory. So you have some factory workers and you will try to elicit the effect of that chemical leak by doing a cohort study, and you will see if there is any occurrence of skin diseases among the particular uh, factory workers. So here you won't have similar cohorts. You need to have another cohort in a particular area from the general population, and you will have to compare between your exposed population and non-exposed population. So these type of studies where there is very rare occurrences or very small cohorts, it is called double cohort study. So this is the analysis. As we mentioned, we will have the effects, let's say cigarette smoking. Some of the persons, they are smoking cigarette. The total maybe 10,000 population, 7,000 are smoking cigarettes and 3,000 are not. And ultimately, lung cancer was developed among 70 smokers and 3 non-smokers. And so the rest of the persons, they did not develop lung cancer. So the incidence of disease among exposed will be A by A plus B, which is A means the occurrence of disease among exposed divided by total number of exposed. That is the total risk population or at-risk population. So here the incidence of the disease is 10. The incidence of disease among non-exposed, it is C by C plus D. Similarly, occurrence of disease divided by at-risk population. So here at the at-risk population is the non-exposed population. It is misnomer at risk. It is might have been outside risk population. So incidence of disease among non-exposed is 1. So in this case, relative risk will be ratio of incidence among exposed divided by non-exposed, as we discussed. So it will be 10 by 1 equals to 10. And what will be the attributable risk factor or attributable risk? Anyone? Can anyone say what will be the attributable risk in this particular example? You can, anyone can have the mic. Fatima, you can ask people to interact also.
Yes, so that'll be great.
Yeah.
Would anybody like to answer? You can raise your hands and I'll unmute you so you can.
The question is, what is the attributable risk in this particular example? How much of the lung cancer is attributable to cigarette smoking? Okay.
Yeah, so it has to be listed incidence in exposed minus non-exposed.
Yes, yes.
So that's what you're looking for.
Yes, you are absolutely correct. So the attributable risk is nothing but the difference of incidence of disease among exposed and the incidence among non-exposed. So it will be anyone? It
9.
will be 10 minus 1 divided by 10. That is 90%. So 90% of the, yes, Suchita, she told correctly, 10 minus 1 divided by 10, we have to divide it by the denominator. So 90% is the attributable risk. That means 90% of the lung cancer, it is attributable to the cigarette smoking. Very good. Can anyone have the population attribution risk, PAR, from here? Suchita is correct. You can just write in chat box also. If you are shy to speak up, then you can write in chat box also your answer. Okay. So the population attributable risk, it is the difference of incidence among total population and the incidence among non-exposed. So here the incidence among total population would be 0.73, 73 per 10,000. And incidence among non-exposed will be 1 or 0.01. Then we have to divide it, which is 6.3 by 7.3. It comes around 82%. So population attributable risk is 82, which means that if all of the subjects, all the 10,000 subjects stopped smoking, then the incidence of lung cancer will reduce by 83%. So you just calculate it and just you do it in your own place and time. Okay. Now going to the next slide. There are some biases in cohort study. So what is bias? Bias is nothing but a fault in our organization or fault in our system in the study, which actually affects the result or which affects our methodology. It is called bias. So there might be some selection bias. When we are trying to include workers, as they are having more chances or probabilities of exposure, we might negate the effect of exposure by this selection bias because most of the workers are physically active, so they might be healthy. And the association and the result might mask the effect of the, let's say, exposure. There is a one very important problem in case of cohort study. It is loss to follow-up. as it is a longitudinal study, going prospective, there is a chance of loss to follow up. So this is a very important bias in case of cohort study. There is also another bias, it is called misclassification bias. Misclassification bias, it is you are classifying the cohort wrong. You are selecting your cohort or your comparison group wrong, which is called misclassification bias. And lastly, confounding bias. It is present in all the studies. Now coming to the case control study, it is just opposite to the cohort study. So in cohort, you are having the exposures and you are going through the time, or you are going longitudinally to see the disease prevalence or occurrence, and then comparing between the disease occurrences. Here, you actually have two type of population, which is case and control. And case and control means both the exposure and the outcome has already occurred before the start of the study, which means there are some patients with the disease, they are called cases, and there are some similar population that we will select, they are called controls. And we need to proceed backwards from effect to the cause. It actually uses a controller comparison group that I actually said to support or refute the inference. We have to compare between two different groups so that we can test our hypothesis, right? So we have to support our inference by having another control group. Now, first of all, we need to select cases and controls. Then we need to select a particular measure of a past exposure. We need to select the past exposure on the basis of literature or existing knowledge, and then we need to have we need to extract the data of that particular exposure. So here we can have a 2x2 table. Here we can see A is the cases who were actually exposed, B are the controls without disease who were actually exposed, and C are D were cases and controls respectively who were not exposed. So total number of cases are A plus C. Total number of controls are B plus D, and the proportions who were exposed are A by A plus C and B by B plus D. So this actually seems or looks very similar to the analysis of cohort study, but it is very different. You need to understand the difference of analysis between cohort study and case control study. So I will come into that part later. First of all, let's discuss about the steps of case control study. The steps of case control study are very similar to cohort, just the direction is opposite. First of all, selection of cases and controls. So you have to select very cautiously your case and controls, and you have to match them. You have to match them regarding all the possible variables, all the possible other exposure, which might have a say on the disease occurrence. So apart from the exposure on investigation, we will try to match the case and control in all other areas or all other characteristics. Then we will have to measure the exposure from different records, maybe hospital prescriptions or records of some other type of other format of source of data. We will have the measurement of exposure. And lastly, we will analyze in form of exposure rates, not disease rates. So you have to be very cautious about saying the terms here. Here the disease has already occurred. So you can't say incidence or disease rate or incidence rate here. Here you might have to say exposure because we are trying to measure the exposure. And another one is odds ratio. So what is exposure and what is odds ratio? I'm just coming in the analysis part. So first just see what are the criteria for control selections. Controls you have to select in the first criteria, and the only criteria is disease status. The control should not have the disease of interest. It should come from same study base or population as cases. So there is no double cohort in this. You have to be in a single cohort or single base. It can come from geographic samples or medical institutes, neighbors, friends. Any type of or any group of patients or subjects who have similarity with the cases. And they might be or they must be may is not a good term. They must be matched by age or weight or sex or any other factors. So matching the known factors, known confounders, most of them are socio-demographic factors. They are done in two methods. First is group matching and another one is individual matching. Group matching is you just have a group of cases, you do their average datas, average values of socio-demographic characteristics, and you match a group of control whose average is similar to that of cases. This is called group matching. Individual matching is that matching will be done for individual cases. So individual matching is better, but also many like it is manifold difficult from group matching. Now, analysis is only two types of analysis are there. One is exposure rates among cases and controls, and another one is estimation of disease risk associated with exposure, which is odds ratio. We can't have relative risk because we are not going prospective way. We can have only odds ratio. So, what are the exposure rates? Exposure rates are similar that I discussed with you. In that particular case, the exposure rate among cases will be A by A plus C. Because among the cases, that is the 35% of lung cancers, 33 are smokers or exposed. They are having the exposure of investigation. So here the exposure rate is 33 by 35 equals to 94.2%. In case of controls, among controls, the exposure rate is 67%. Now we have the exposure rates by simple division of our exposure values and disease values. Now we will try to estimate the risk. Now, in case control study, we actually cannot calculate the incidence of the disease, as we are starting with both disease and exposures has happened. So there is actually no appropriate denominator. We can't have at-risk population. So we can't say relative risk. Risk cannot be said because we don't have the risk population, at-risk population as denominator. We discussed about the denominator in details in the measures of disease frequency. Therefore, we actually calculate odds ratio. Odds ratio means how much odds, what odds of the disease or what odds of the disease which is associated with a particular exposure. How much odds with comparison to the control groups. This is called odds ratio. So how to determine the odds ratio? So odds ratio is a measure of strength of association between risk factors and outcome. And it is also called cross product ratio. So why cross product ratio? Here we can have the exposure and the disease. And the calculation is A by B. A by B is the exposure, among the exposure, the disease rate. And C by D is among the non-exposed, the disease rate. So A is the odds of developing cancer among the exposed group, A by B. And C by D is the odds of developing cancer among non-exposed. So these two particular odds we are dividing, or we are having a ratio. So A by B, the odds of developing cancer among exposed, divided by C by D, the odds of developing cancer among non-exposed. So the calculation comes as AD by BC. So it is actually in the 2 by 2 table, it is a cross product ratio. Now here in the particular example, we see that the case were persons with head injury in road traffic accident, and the controls were without head injury. And the exposure was, or the risk factor in this particular case, was not using seat belt. So we see that in case of not using seat belt, the odds of developing head injury was 850 by 600. We all know about the odds of having winning a race or not. The type times they are having cases is the positive odds or the numerator, and the negative will be in the denominator. So 850 by 600. And among the non-exposed group, those who actually used seat belt, the odds were 150 by 400. So here the odds ratio will be 850 by 600 divided by 150 by 400, which means 850 into 400 divided by 150 into 600. That is 3.78. Now, this actually interprets as the chance of people not wearing seat belt, the chances of having cases among the people not wearing seat belt, it is 3.78 times higher in comparison with the people who did not use or rather who used seat belt. So odds of having head injury among persons who don't or didn't use seat belt is 3.78 times higher. So why we are using this? Why we are using this odds ratio? We are using this odds ratio to have a idea, clear-cut idea about the future. So in the future, we can recommend that those people who are actually using seat belts, they are 24% better protected than the persons who are not using seat belts. So odds ratio is important in this way. Now interpretation is same. If the odds ratio is more than 1, then the frequency of exposure is higher among cases, which indicates increased risk. If the frequency is lower, then the odds ratio will be less than 1, which indicates possible protection. And if it is 1, then there is no association of risk with the exposure or the defect. So this is very straightforward, the interpretation of odds ratio. Now the biases in case control studies. This is also very important. Some of the biases are common in cohort study also. First of all, recall bias. Because you are going back in retrospective manner, you are going back to find out the measurement of exposures. So if you go 10 years, 15 years back, many people might not have accurate data or accurate information about the exposures. So recall bias can be there. Selection bias is very much common in case control study, even more than cohort study, if you do not match properly. Barkesonian bias is very important. Barkesonian bias is what? Barkesonian bias is if we are doing a case control study in a hospital setup, there might be different rates of admission in that particular uh, hospital in different times. So when you are going to have exposure measurement for a particular period, let's say 5 years, there might be some let's say a particular disease, let's say lung cancer. In a particular hospital, there might be low admission of that lung cancer cases, which will have more difficulty or a possibility of negative findings of the exposures. So this is called Barkesonian bias. Interviewer bias, as we already know what happened to the patients and what didn't happen to the patient. We all know who will be the cases, who are the controls. So we might ask more vigorously to the case, the patients. And we might not ask so devotedly to the controls. So it is interviewer bias. And lastly, confounding bias. All the third factors that we don't know that might have influenced the cause and the effect and the cause. There are some special type of case control study. Although I know that most of the audience here are undergraduates, but I think you need to know at least the names and the basics of this special type of case control study. So these are actually not case control study. These are hybrid studies, but they are the methodology is similar to the case control study. So we will just discuss very briefly about these three type of special studies. So firstly, nested case control study. So what is nested case control study? Nested case control studies, you will go retrospectively. So you will have some cases and you will have some controls. Then you will measure their exposures. But at the start of your study, nobody would have developed the disease. Okay. So you will have a defined cohort. So it is a hybrid of cohort and case control. So see, in the left-sided diagram, you have a defined cohort. Some of will develop disease, and some will not develop the disease. You know the disease in question or disease in investigation. So whenever first case appears from that particular defined cohort, you will have another control. Second case appears, you will have another control from that particular cohort. And like this, you will go to the specific period of time. Let's say you are trying to see for 5 years. Then at the end of the 5 years, you will have 5 cases and 5 controls. So it is very important to have the idea of nested case control and why it is important, why it is actually better or superior than normal case control. Because here the case and control, they are from a defined cohort, similar cohort, and they are having like one-on-one comparison. So the matching is way better than normal case control study. So this is a type of nested case control study. So what is case cohort? Case cohort is as like similar to the nested case control study, but here rather than selecting controls step by step as and when cases happens, you select control at the end of the period. So what is the advantage of this case cohort study? Case cohort study advantage is in case of nested case cohort, when you are, let's say, after 1 year selecting a control, after 3 years, that control might develop a disease. That control will be converted into case. So there will be difficulty in again allocating another control. So there is a limitation in nested case control, which is masked by case cohort study. Here we are not taking control step by step. At the end of the study, we are taking 5 controls, 5 cases. Then we go back retrospectively. That's why it is case control study. And lastly, it is case crossover study. This is very important. This is done in the diseases which have multiple risk factors, or it is maybe an intermittent disease where the disease happens, then doesn't happen for a while, then it again happens. It might be stroke patients. It might be seizure patients. So in this case, the patients are their own controls. And we will compare the exposure during the disease period, and we will compare the exposure during the intermittent period or cases where there is no diseases. See the pink shaded line. Pink shaded line is the at-risk period when there is disease going on. And the uh, white areas are the intermediate areas where the disease is not going on. And we try to compare the exposure value in the same individuals. So it is called case crossover. So you need to have a good idea about these 3 types of case control studies. Now we go to the experimental study designs. I won't go into the details of experimental study designs because the seminar is already going on for, let's say, more than 1 hour. So just to name a few: randomized control trial, non-randomized when there is no randomization, clinical trials, community trials, and quasi-experimental study. So these are the 5 main experimental study designs. The difference between community trial and RCT, I have already explained. So RCT, the basic design is you have to draw up a protocol at first. Then you have to select a reference and experimental population. So the reference population is the, let's say, population of West Bengal or population of, let's say, Uttar Pradesh or a particular district of Uttar Pradesh. From there, you will select experimental population. That selection of person, it will must have the ethical clearance. They must have the consent into entering into that particular experimental design. And there is some different methods for allocating the cases or selection of cases. Then you will do randomization. This randomization can be done in different way. Randomization can be done individually. Individual randomization can be done by maybe lottery method or random number generator. We can have random number generator in Excel, Microsoft Excel also. The randomization can have stratified randomization. To better the better the competitive groups, you might have stratification. You might divide the groups as per age group or gender and then randomize. Then you will have to manipulate or intervene. You have to intervene the particular experimental group, and you have to have less intervention or different intervention in the control group. Then you need to follow up. Follow up need to be periodical, not one time follow up. You need to periodically follow up. And lastly, you need to assess the outcome. So, Fatima, there is some markings on the screen. Can you just remove it?
Yes, so give me a minute.
I think there is some marking in the slides. Okay, thank you. So, what is the important and the specific unique thing about RCT? You need to know about randomization. If nothing else, you need to know about only one thing, that is the randomization. So, randomization is called the heart of any controlled trial. It actually ensures that participants, all the experimental population, they have an equal chance to be assigned to one or more, which means that any person coming to that particular experimental studies, they have 50% chance to be allocated in the experiment group and 50% chance to be allocated in the control group. If there is only two groups, if there are three groups, then he must have 33% chance of being allocated in each group. It is like that. And randomization actually provides the best way to prove the effectiveness of any drugs or vaccines or interventions, because groups are similar. It is similar as much as possible, and it allows for comparison. So randomization is the only way to reduce unknown confounding factors also. You are randomizing, you are giving the participants equal chance to be assigned in every groups. Thus, you are increasing the comparability and you are minimizing the confounding and bias. So it is very important to ensure that you don't have any confounding factors, or you minimize confounding factors. You cannot possibly eliminate confounding factors. You can just minimize it, but you can eliminate the selection bias. So this is important part of randomization. Now, if you go to the next slide, there are some biases in RCT. Although we are saying that bias we are reducing, there might be some subject variation bias, because if the patient knows that he is treating or he is receiving a new form of treatment, he might say that he is subjectively feeling well. So this is bias due to subject variation. There might be some observer bias, because the investigator who is measuring the outcome of a, let's say, clinical trial, he or she might be influenced if he or she knows beforehand that that particular drug or particular therapy, it is hypothesized to help the patient or improve the patient. So there might be observer bias. There might be evaluation bias when the investigator trying to give favorable report in a particular group. And lastly, there might be publication bias. So we do all the studies. Our end goal is to publish it in a reputed journal, so that our scientific rigor or our scientific effort is shown worldwide. So now there is a thing called publishing bias, where we tend to mask or we tend to shunt the negative results. So the conclusion or the calculation might be erroneous. So how to reduce this bias in RCT? there is a very efficient or very effective way to reduce all the biases in this ICT. It is called blinding. So any type of trial, they are actually blinded. They are blinded in three ways or three layers. First of all, single blinded, secondly, double blinded, and lastly, triple blinded. Single blinded is actually only the patient. He or she will not know in what groups he is being allocated or at what groups he or she belongs during the study period. It is called single blinded trial. So this trial will actually eliminate the bias due to subject variation that I discussed. Double blinded is neither the investigator is observing the effects nor the participant is aware of the group allocation or the treatment. Which treatment they also don't know, and group allocation also don't. So actually it will eliminate subject variation and additionally the observer bias. And lastly, the triple blinded trial. Here the participant, investigator, and also the analyzer, the person who will do the data analysis, all of them are blinded, which means none of them knows which persons belongs to which group, and none of them knows which treatment is given to which group. So this will eliminate all the bias except for the publication bias. So publication bias, only conscious can eliminate or reduce publication bias. Okay. So although RCT is very difficult or RCT is very advanced epidemiological study and which is very rarely done in normal public health practices, but you need to know about two main study design of these control trials. Now, the most common type of RCTs are called concurrent parallel study design. Here, their comparisons will be made between two randomly assigned groups, where one group exposed to specific treatment and another group is not. So participants will be randomly assigned. Some will be exposed to specific treatment, another will not be exposed. And after a specific set of time, we will compare between the outcomes. Outcomes might be incidence, outcome might be another morbidity rates or mortality rates or any disease frequency measurements. So this is very simple. There will be two groups. One is experimental, one is control. We will do randomization, and after a while, we will compare outcomes. So this is concurrent parallel. Now, the second part is crossover type of study design. It means those who receive treatment under study at the start of the study, they will change into control group. And the control group, the persons who are at the start of the study were in the control group, they will change into the case. So the participants, they will interchange groups. And at the end of the day, we will compare outcome amongst exposed and unexposed to treatment. So here we will compare in different time. We will compare before crossing, after crossing. So you might say that why should we do, sir? Why should we do this type of crossover type study design? Parallel is very straightforward and it's very simple to have the outcome analysis. Crossover study is done to further reduce any difference between the difference of other possible variables between the different groups. Which means if a particular, if let's say, even after randomization, the people who were in the control group, they were, let's say, more immunologically sensitive, or they are having, let's say, more good nutrition, better nutrition, or they are undergoing better lifestyle choices. So the disease occurrence will be affected by those particular variables. That's why after a specific time, we will interchange them. We will give them the treatment. The specific treatment intended to reduce or increase the particular outcome so that we will have more and more compatibility. So crossover type of study design actually ensures more compatibility than the concurrent parallel study design. Now, different type of RCT I have already told, different type of experimental study I have told, but there are some different types of RCT and I want you to know this because in my experience, when I am doing the public health, when in my field work, in my public health experience, I am also involved with a few of the control trials. So clinical trials, as you all know, that you will have a new therapy or new intervention or new drug, and you will have to have an experiment group and control group. And after a while, you will just compare the outcome of question, and you will see that if the drug is good or not. Preventive trial is in place of drugs, there will be some preventive therapy. It might be some lifestyle choices. It might be some health promotions. It might be some specific protection such as vaccines. So right now in India, there is a preventive trial going on. It is called adult BCG vaccination trial or study. So it is actually a type of RCT that is going on in 260 districts in India. So here there are some experimental districts or case districts, and there are some control districts. The case districts, they are undergoing the adult BCGs, they are taking the adult BCGs, and the control districts, they are not taking the adult BCGs. So after a while, the outcome will be incidence of TB, incidence of notifiable TB in the two type of groups, and we will compare the outcome or compare the incidence. So now this is preventive trial, and it will be compared in individual basis. So if it is compared in individual basis, it is RCT. If it is not compared on individual basis, if it is compared only by districts, then it will be a preventive community trial or field trial. In field trial, the basis of unit or the base unit is community, and in RCT, the base unit is individuals. There are some other type of RCTs also, like cessation experiments, etiological event trials, and evaluation of health service. We don't need to go into the details of these things. These are just the mode of intervention or mode of manipulations. Uh, there are some type of results that we want to see from the randomized control trial. These are efficacy. Efficacy is a very important measurement way of RCT. It might be the most important way, and we need to know what is efficacy. All of us, we need to know what is efficacy in RCT. There is some absolute risk reduction, ARR. There is relative risk reduction, RRR, not the cinema, relative risk reduction. There is some reduction in incidence density, number needed to treat, very important, and number needed to harm. So let's just know or have an idea about what these terms are. So efficacy, as you see, it is how well a treatment works under ideal condition. So we always try to use efficacy, effectiveness in our day-to-day life conversations, right? So efficacy, you can only say efficacy of a particular disease, efficacy of a particular agents or drugs or vaccines or treatments or therapy. It is only under ideal condition. Okay. And in RCT, we try to say that it is ideal condition because of the robust methodology and stringent case division techniques or patient division allocation techniques. So efficacy is rate in those receiving the placebo. Rate means incidence rate minus rate in those receiving the treatment. So by hypothesis, this rate should be more than this rate, divided by rate in those receiving the treatment. So this is the efficacy. So let's say the treatment is adult BCG in my example. So TB rate in the placebo group or placebo district, let's suppose it is 50 per 10,000 population. And in those districts that received adult BCG vaccination, it is 20 per 10,000 population. So the efficacy of adult BCG will be 50 minus 20 divided by 50. It is 60%. So we will say the efficacy of new vaccine is only 60%. So if it happens like this, there might be no further adult BCG in a large scale production or large scale distribution. So RCTs are very important in evaluation of public health programs or evaluation of public health services also. So efficacy is, we can all understand very easily what is efficacy. Then coming to the next point, it is number needed to treat. It means the number of patients who would need to be treated to prevent one adverse outcome, such as one death. So adverse outcome means number of patients that need to be treated with that particular new treatment or drugs to prevent that adverse outcome. So how to have the analysis or how to have the calculation? So NNT is 1 minus rate in untreated, 1 divided by rate in untreated minus rate in treated, which means if the mortality rate of untreated group is 17% and in the treated group is 12%, then we would need to treat 1 by 17% minus 12%. It is 1 by 0.05. So 20 people. So if we give the particular drug to 20 untreated people, then we might prevent one death among those 20 patients. So this is very important for life-saving drugs. These were also very important during large-scale distribution of COVID-19 vaccination. They found out the NNT for COVID-19 also before large-scale distribution of this. That clinical trial did not have so much time to develop. So number needed to treat was very important for that particular study also. Number needed to harm. So it is nothing but the opposite of this number needed to treat. It is epidemiological measure that indicates how many persons on average needs to be exposed to the risk factor over a specific period of time to cause harm in an average of one person who would not otherwise have been harmed. That means in the unexposed person or unexposed group, how many person needs to be exposed to a particular risk factor so that among the unexposed person, one person will get involved or get the disease. It is similarly 1 minus incidence in treated group or exposed group minus incidence is control group. So NNT was 1 by incidence or disease rate in untreated minus disease rate in treated. Here incidence in treated will be at the first, and then incidence will in the untreated or unexposed or control group. There is also reduction in incidence density. It incorporates actually the length of time taken by the treatment to obtain one unit of benefit, expressed in terms of number of person years. Example is when warfarin treatment is given to in a long-term basis to prevent stroke in patients who have atrial fibrillation. So this was one of the clinical trials. So the benefits are reported in terms of reduction in stroke per 100 patient year. So let's say 10 patients had been prevented in developing stroke and the study period goes to 10 years. So 10 years of warfarin treatment prevented 10 patients from having stroke. So the reduction in incidence density is 10 patient into 10 years equals to reduction in stroke in 100 patient years. So this is the way to express reduction in incidence density. And absolute risk reduction or risk difference, it is same as the relative risk. It is risk in exposed minus risk in unexposed. And when we divide it by the risk in exposed, it is basically attributable risk factor. Relative risk reduction is nothing but attributable risk factor. So when you are doing the having the intervention, the group having the treatment as the protection, or maybe they have the chance of reduction in the risk by 60%. So this is the just the interpretation of relative risk reduction. Now coming to the last topic of today's discussion, long discussion, it is the validity and reliability of any particular study or disease, or maybe a diagnostic treatment. So validity is nothing but the accuracy, which you are trying to measure, which you are supposed to measure, you are measuring. It is like a bull's eye. If an archer can specifically hit bull's eye, then we will say that the archer is valid or precise or accurate. So accuracy is how close is result of a test to its true value. So here you are seeing that two type of uh, sorry two type of archery plates, and here we are seeing that in the first type there is high accuracy, like the archer is just putting or hitting the arrow in the inside circle, small circle, but it is not going on good precision. The precision is low. Precision means you will hit on the same spot always. Means you will repeat the same performance again and again. But in the second board or the archery board, you can see that there is high accuracy and high precision also. So the arrows are hitting on the inner circle and all the arrows are hitting on the same circle. So accuracy means validity in a particular test measure or a diagnostic test or diseases, and precision is or repeatability is called reliability. So if you have good precision, then you are a reliable test. If you have good accuracy, you are measuring what you are supposed to measure, then you will be a good validity, a test with good diagnostic accuracy or validity. Now, reliability, I just gave the same example. Here you are seeing that in the top board, there is precision, high precision, but low accuracy. So this particular test will have high reliability, but low validity. And the second one will have both high reliability and validity. So validity of a test or any diagnostic or screening test, it is actually two types of this. It is sensitivity and specificity. And together, these two will actually have the diagnostic accuracy. And with diagnostic accuracy, there is something called predictive accuracy also. And all of these four things, they are actually inherent properties of a screening test. Now, again, the same 2 by 2 table of test positive and diagnosis positive. So here we are seeing a particular screening test or diagnostic test. If it is positive and actually the diagnosis is there, so it is called true positive. That is the A. If the test is giving positive result, but actually there is no disease, so it is B. It is false positive. The test is giving false positive result. If the test is giving negative result, but there is actually disease, then the test is giving false negative results. It is the C. And lastly, test is giving negative result and the diagnosis, actual disease is not has not occurred, then it is a true negative. That is D. So total number of diseased patient is that this particular example is A plus C, and total number of patients who does not have disease is B plus D. So sensitivity is the ability to detect true positive among diseased case. So you need to know this. Sensitivity is the ability to detect true positive cases. So what is true positive? It is A. So sensitivity will be A divided by A plus C into 100. A plus C is the total number of diseased. So denominator will be among diseased people and numerator will be true positive. This is sensitivity. Similarly, specificity is the ability to detect true negatives among the negative people or among the control person. So here the denominator is the control person, the person who have not developed the disease, that is B plus D, and the numerator is the true negative, that is D. So sensitivity is A by A plus C, specificity is D by B plus D. In this particular example, you need to understand that for sensitivity, the numerator will be true positive, and the specificity, the numerator will be true negative. Now coming to these two are diagnostic accuracy. Now there are another two components here. In case of validity, it is called predictive accuracy, or it is called predictive value of a positive test or positive predictive value, and predictive value of a negative test. That means how much possible or how much, what is the possibility of the test to give positive result and the possibility of the test to give negative result. So here the numerator will be same, the true positive, but the denominator will change. The denominator will change from total diseased to total positive. That means out of total positive, how many true positives are given by the test? It is called predictive value of a positive test. So positive test is the total denominator. Out of those denominator, how much is the actual value of the test? How much is the predictive value, correct predictive value, which is A. So positive predictive value is A by A plus B. Similarly, negative predictive value is the possibility or probability of true negative among the all negative test cases. So predictive value is of both positive and negative tests. Now, I will not go to the details of the sensitivity and specificity, but you need to know that predictive value of a test, it actually reflects diagnostic power of the test, and it depends on the sensitivity and specificity, which are inherent properties, and also the disease prevalence. So, how disease prevalence is important in predictive value, you must know that if a disease is more prevalent, that means the percentage or proportion of people with the disease, if it is more, then the predictive value will be more accurate for a positive test. So here a predictive value of a positive Gram-Stein cervical smear test is shown. It has a constant sensitivity of 50% and specificity of 90% because Gram-Stein is a particular test and each of the tests has their inherent properties such as sensitivity and specificity. But it has been tested in 3 different populations with 3 different levels of prevalence. So if we see at the population of prevalence 5%, the total number of smears done is among 100,000 people. And the prevalence is 5%, so positive culture is only for 50. As the sensitivity is only 50%, then among 50, only 25 will be true positive. Then 25 will be false, what? False negative. And it is 95% specificity. They have to. As prevalence is only 5%, the negative cases is 950. As the negative case is 950 and the specificity is 95%, then the specificity will be 95% of 950, which is 855. And the false positive will be 95. So here the positive predictive value will be true positive divided by all positive, which means 25 divided by 25 plus 95 equals to 120. This is 21%. So the positive predictive value is 21%. But similarly, if we increase the prevalence, the true positive will increase. The false positive will not increase or will be comparable, but the true positive will increase and the percentage and proportion of true positive among the total positive cases will increase, which is the positive predictive value. So positive predictive value increases with more prevalence and negative predictive value decreases with more prevalence. So this is the important thing that you need to know about the validity part. False positive, false negative, you all know. But there is some ways to appraise validity. Not only this particular test, there might be tests where there is no particular cutoffs. You won't have any dichotomous value, which means this is yes or no. There might be some newer drugs or newer interventions or questionnaires of which you need to find the validity or accuracy. So this can be done by 2 methods. One is on the method of judgment, on the basis of judgment. How? We'll have the experts check your questionnaire or check your checklist, and they will check with the operational definition. And they will understand if the measures appears correctly to the appropriate conceptual definition. If the tool or if the questionnaire will measure the correct definition of the disease. And another is the basis of check second data. This data is like pilot data. There will be some pilot data which will represent the total population, which will be a sample which will represent the total population. And from that data, we will have analysis of appraising validity. So judgment basis, you might have subjective errors. But if you do appraise the validity on the basis of checks against data, the subjective error are reduced. So there are some different types of validity. You don't need to go into the details of it. You will need this when you go on to have the research methodology proper. When you are going to do a particular set of a questionnaire for a particular study, then you need to assess or need to appraise the validity of your questionnaire, the validity of your study tool, the validity of your diagnostic test. So what is face validity? Face validity means you are seeing it and you are thinking that, yes, this particular tool can measure a particular set of parameters or health events. If I see a digital weighing machine, then I will know that this machine is supposed to measure the weight. If weight is the outcome of investigation, then I will say that by face validity or by judgment, the tool is valid. There is some content validity. Content validity means with some weighted average of opinions from different expert committees. So these are called content validities. There are some validity checks on data, like predictive validity, as we discussed, positive predictive value, negative predictive value. There is some criterion validity, convergent and discriminant validity. It actually decides if your components of questionnaire, they do not vary so much if we just change or reduce or omit one of the data points. The ultimate outcome will not change as much as possible or will be similar as much as possible. This is called criterion validity. There are different types of validity also, construct validity. So these are based on check second data. So you have to do some pre-test, you have to do some pilot data, and from that data, you will have this kind of validity measures. Lastly, reliability. Reliability is the extent to which similar information is obtained. As I said, it is the repeatability. So there is less and less variability in measurements if you do the test or if you do the experimental study or epidemiology study multiple times. Now, there is some type of variations that you need to understand, which might happen and which might reduce the repeatability. It might be intra-subject variation. Like I am measuring blood pressure of a patient right today, and tomorrow I am measuring the pressure of the same patient, but it might happen to me that my perception of sounds might differ from one blood pressure level to another blood pressure level. In the same patient, in different time period, I will interpret in different ways. Measuring instrument might not be calibrated. That's why variation of observation can be done. And due to various observers, there might be observers who are observing a particular study or disease. Between observer, variation can be done, and within observer, variation can also be done. Now, only one type of reliability is important for us, the UG and PG students, mostly, that is percent agreement. Percent agreement is inter-observer variation. So it actually assesses the quality of two variables or two observers. Now, two observers might be two physicians or two nurses, maybe two radiologists who will see the same USG report, and they will classify the outcome as maybe diseased or not diseased. Here it is written as abnormal, suspected, doubtful, and normal. Here they have classified the disease spectrum in 4 different types. And here there might be 16 type of variation. As there are 4 types of observation, if we have 2 observation or 2 observers, there will be 16 combinations. Out of these 16 combination or readings, only A, F, K, and P, these four are similar between two observers. Like in these four, they are in agreement. So these four divided by the 16, it is very simple measure. It is called percent agreement. The higher is the higher the percent agreement, the higher the reliability of a particular tool or particular test, diagnostic test. So this is the basic concept of validity and reliability that you need to understand. I think my presentation is at the end. So if you have any questions in the chat box, you may proceed with it. Over to you, Fatima. Any questions in the chat box?
We'll give them a minute to send in
Okay, okay,
questions, sir. If nothing comes in, I have a question for you in the meantime.
okay.
So in the real world scenario, as a researcher, like what are the most common issues that you come across, particularly in experimental study designs, because those are considered like the gold standard of study design. So including ethical issues as well.
Yes, yes.
Yeah.
I skipped the ethical issues because
Mhm.
it would take me another class to say about the
Right.
ethical issues. And it is not only important in case of
Mm-hmm.
experimental studies, it is actually important for all studies. Because when you are
Right.
trying to incorporate individual information, you are trying to incorporate human information, you need to have ethical issues, you need to uh, abide by some principles, some principles of ethics. As we know, there is something called principle of uh, beneficence, principle of non-maleficence, which means you are actually benefiting the patient. At the end of the study, your aim should not deviate from any benefits that you could have given to the participants. There is principle of non-maleficence. Whatever you do, you must not harm the patients or must not harm the participants. So there are some ethical principles that you need to follow. What particular challenges that the researchers, especially the beginners in the research arena, they face, in my opinion, in case of experimental studies, it is the selection, it is the protocol writing, and it is the selection of study participants, especially in case of RCTs. This is very difficult for an RCT to retain the participants. They have the ability to go out and not ever coming back in any time, any particular specific period of time. And so to retain the participants, it is the most important part or most important challenge in case of RCTs. And if you say non-RCTs or observational studies or experimental descriptive studies, the most challenging part for any researcher, I will say, is to actually generate the hypothesis. That is the most important part that we like regularly omit and regularly, actually we don't give so much emphasis on our hypothesis generation. But if you do very rigorous or very structured literature review and hypothesis generation, your study will go smoothly. This is my own experience. This is my own experience from my PG time and my publications and all. Uh,
Right. So,
yeah,
yeah,
that
that was
makes
extremely
sense.
insightful. I mean, we know what it feels like to actually do research now,
Yes.
on the ground. Yeah, so there are a couple of questions on the chat
Oh,
now.
okay.
Someone wants to know, can you explain case crossover study with an example?
Okay. Okay. Very, very interesting example I can give. So there, there was a important uh, study in UK among the ischemic and hemorrhagic stroke patients. So what they were doing, they were associating the stroke patients or the intermittent stroke patients, like they were going to the hospitals, they were getting the conservative treatment, or some of them might get the craniotomy treatment, and they were relieved of the clot inside the brain. So they were improving. So in a period of time, they were having the CVAs, and after a period, they are not having the CVAs. But the commonality among those patients were all of them were bikers. So all of them were actually exposed to road traffic accidents, or maybe risk of getting road traffic accidents. So what they are they were trying to do is to have the exposure of wearing helmets, or any other type of little bit small exposures that that they were comparing with the intermittent period and the stroke, maybe the during stroke period, or just preceded period of the stroke. And they were comparing the incidence of CVA among those particular patients only with the exposure. Like if there is exposure, like if the person is not wearing helmet, let's say for 2 months, only 20% times he is wearing helmets. And then among those people, then in the next 1 month, 4 or 5 severe episodes happened. In the same patients, after it, they increased the increased the incidence or occurrence of helmet wearing for next 2 or 3 months. Then after that 2 months, maybe the CVA occurrence reduced to 2 or 1. So they will compare CVA occurrence in the same patients in different times, and they will associate it with the preceded exposure rates. So here the main thing is the case are their own control in different time periods. So that is one of the example of example of case crossover study. There was a very big study in UK in this, and there was also another study for case crossover study. It was done in India. It was for dengue, but it was done in a big community way, not in an individual way. Here also, for the similar patients, the dengue protective activities were measured during times of dengue outbreaks and during times when they were not suffered by dengue. And they were seeing that during the time period of their dengue incidents, they were not having protective factors like not wearing mosquito nets. But after that, when there were less incidents of dengue, or maybe they were not affected by dengue, they were wearing the mosquito nets. So this is a type of case crossover study, which is essentially a modification of case control study, where the case is their own subset. The control is the own subset of case.
Thank you so much, sir. That was interesting. Sayan, I hope that answers your question. He has another question. Is an ambispective study a type of descriptive study?
Ambispective study can be a type of descriptive study, but you have to think of one thing only. You have to look on the feature of the descriptive study that I discussed. If you do not bother, or if you do not uh, do any type of analysis, if you don't dwell into the determinants of the disease, then it can be a descriptive study. That's why ambispective study, cross-sectional study can be descriptive study. If only if only distributions is part of that particular study, then they can be descriptive study. This is a very good question, because I also were confused when I was reading this particular temporal association, like temporal difference of different studies. Temporality has nothing to do with descriptive or analytical.
Okay, sir.
Descriptive and analytical is 100% to do with your own methodology. Okay.
Okay, so thank you so much. Yeah, so another question that I also had for you was, as people who are just starting their journeys, or who hope to start their journeys in epidemiology and public health, like what advice would you have for them? And the students are also asking about what books to read as beginners in research. Yeah.
This is very good question. So when you are beginner, so you need to understand if you are UG or you are preparing for PG or preparing to go to the public health arena. So public health, as we all know, is a vast area, and I am very interested to talk about public health. You can have different paths. You can have different areas where you can venture, you can excel or prospect. So the main thing that you need to do is not to lose trust. There might be challenging periods. There might be periods when we will not be, you will be confused what to do, what not to do. The main thing is to not lose trust. And the second main thing is to do is to develop a niche area of your own. Maybe you understand it more, maybe you prefer it more, maybe you like it. Developing a niche area is very efficient, or very, it makes it easier to focus on the particular area where you can go. Like if you take my example, right now I am in core public health activities. I am uh, involved in disease surveillance and various public health strengthening activities such as immunization. So actually, I like infectious disease and infectious disease epidemiology, this part. So it is that my studies and my part of niche areas, it should coincide or overlap somewhat to my work experience. That will make it easier. And if you want to know about the books, I think Aryan, I think some of them asked about the book.
Yeah, science or
Science asked about the
science.
book.
Yeah.
For epidemiology, I will say Leon Gordis is a very good. Leon Gordis is a very good book for beginners if you want to know about epidemiology, and also for research, because research has two parts. One is to understand the different types of epidemiological studies that we discussed today, and another part is how to proceed with your protocols. So personally, I am an alumni of All India Institute of Hygiene and Public Health, Kolkata. So we had a beautiful collection or beautiful set of brilliant academicians in my. I was lucky to have my teachers, very great teachers. So I actually only read the research methodology book of my own HOD, Dr. Bobby Paul, Madam, Dr. Indonesia and Dr. Bobby Paul. So their biostatistics and research methodology is the book that I would recommend for any beginners if you want to go into biostatistics and research methodology. But you want to know about the epidemiology, Leon Gordis is a perfect book.
All right. So thank you so much.
Okay, still, I think I need to write the
Yeah.
book. Leon Gordis I am writing. This is for epidemiology. And the research methodology I am writing. So I have written two books. I won't say that these two books are the only thing that you need to read, but I benefited from these two books.
All
Someone
right.
said, Aryan said ecological studies. I think
Yes, sir. Yes, sir.
I can just spare 1 or 2 minutes about ecological studies, then I will go. So Aryan, ecological studies I purposely left out. Ecological study is amalgamation of descriptive and analytic study. Although in part it is written very ambiguously in middle of those two things, the main thing that you need to know about ecological studies is mostly a descriptive study or trend study at a large population. Large means maybe a region or maybe a country, which essentially have their own ecology. That's why it is called ecological study. So if we just consider, uh, let's say, hunger index of different countries, or maybe we consider immunization coverage, full immunization percentage coverage of WHO ACR, which is Southeast Asian region. We are comparing or maybe just describing the immunization percentages of countries. We might compare, we might only describe, but we are we are not very much interested about individual data. The data analysis is not individual. In case of cohort study, case control study, cross-sectional study, when you are trying to elicit the information, when you try to retrieve the information, you are getting the information from the individual basis. But in case of ecological study, you don't have any individual basis. That's why ecological study has interesting thing called, it is called ecological fallacy, which means the result or the interpretation of the outcome, you cannot generalize it to individual basis. You might have good nutrition, you might practice good lifestyle, but you might stay in a particular ecological community where the average nutritional lifestyle value is very poor. So the ecological study that you are parting, that study will say that you are not getting this particular exposure, that's why you are having poor outcome. But on the individual basis, you are having good outcome. So that's why ecological studies, they have this kind of ecological fallacy, and it is actually needed in case of large scale political events or large scale, let's say the global conference of climate change. There they actually showcased some of the findings from some ecological studies, where you don't need the individual level data, or you don't need the analysis from individual data. So that is the point of ecological study.
Okay, so thank you so very much. That was extremely helpful. We thank you for taking time out of your busy schedule for us. The efforts you had put into your PowerPoint presentation and just your passion for your area of work was really showing throughout. So we're very grateful to you. And I'm sure everybody is going to find everything you taught us very helpful. So thank you once again, sir. Thank you everybody else also for attending. Yes.
Thank you.
Thank you so much. Anything from your end, sir, or should we go ahead and conclude the meeting?
Nothing from my end. If somebody has any query, then I will be very happy to address it. But
yeah, I think it's just all the gratitude that's coming in now.
Okay.
I think we're all done. Yeah,
Thank you.
someone's asking for your email in case they want to get in touch with you later.
Yes. Obviously, I will give in the chat box.
Yes, sir, please.
1 second. Laptop is not functioning correctly. Okay, I'm just typing. This is my personal email account. Okay, so if you have any queries or you want to connect with me, you can just mail in this thing. Fatima, you can see the mail that I have sent.
Sir.
Okay.
Yes, sir. Yes, sir. Got it. All right, sir. Thank you so very much. Have a good night.
Good night.
Thank you, everybody, for attending.